All right. Welcome, dear guests. So many of you could all sit on the front row if you wish. And we wouldn't even need a mic, but for the online participants. Happy to have Lenel here, which will guide us through everything Da Vinci, happening and happened, I guess. And I will be paying due attention because we probably need to implement part of it. So very curious.
Thank you, Christian. Lenel James, Blue Cross Blue Shield Association. Glad to join you today. My presentation is going to be in three pieces: an overview and a little bit of the history of the why and the how for the Da Vinci project as a fire accelerator and what fire accelerators are. I'm going to jump into the detail of some of the variety of implementation guides and use cases that we've worked on. And then I'm going to close with some of the statistics, where we are, what we're planning to do, and how we're doing it in terms of just not only the Da Vinci build, but Da Vinci connectathons and Da Vinci efforts to go into production. Just a little quick background on me. I've been with Blue Cross Blue Shield Association for 20 years. Prior to that, did a stint for 5 years at the third largest public hospital in the United States, providing clinical support for lab, order entry, radiology, and pharmacy. That was back when I was way younger and I could remember everything, so I could support multiple systems. Now, not so much. As part of my work at the Blue Cross, I've been, in the 20 years I've been there, I've been in the standards area. We call it Health IT now. It was the National Electronic Standard Units. So I've been involved in both the X12 standard for claims, also been in the National Uniform Billing and Claims Committee in the US as part of the claims process and working with multi-stakeholders. But most of my time has been spent in HL7, where I've been a co-chair, been a co-author of several standards, and worked with several of the people that are here running this event. That's my background. Let's get into Da Vinci. Before I get going, just a quick question. How many here are familiar and have seen or looked at some of the accelerator work on the HL7 website? Show of hands. Looked at our accelerators. Great. Okay, so I can go a little bit beyond just the basics of accelerators. Also in terms of working with fire, I'm assuming everybody is, but show of hands who have done production build work. Okay, fantastic. All right, well, we will go mostly relatively quick because I'm going to assume, and of course, some of the folks in the audience may not be as much. Okay, Da Vinci. It started with the basis of value-based care in the United States because it's insurance programs that are historically been fee-for-service, but there's been a push by the federal government and a variety of stakeholders to go to value-based care. So I'm not going to pay you per instance of interacting with a patient, but I'm going to be looking at the value you provide for an entire month or a year, and I'm going to pay you based on metrics of quality in your interaction and making a difference in what happens with that patient. Well, with value-based care, there's a risk if I give you a set amount of money, how effective you're motivated to be effective at spending it, but also there's a price to pay if you're not efficient in providing that care. It can be a loss leader. That was a new area to try to make shared risk between the private insurance companies and the stakeholders healthcare that are providing care to make sure we could deal with things as shown on the slide, patient outcomes, making sure we're all responding appropriately to the regulatory impacts on healthcare in the US market, and then looking at costs. How can we be more effective at using technology, trying to provide better care at lower costs was the focus of the Da Vinci project. And focusing on use cases. What are the areas of healthcare that we're going to tackle? There's not unlimited resources. There's a variety of proliferation of things we can work on, but what's the best value for doing that was part of the vision of why we were doing Da Vinci, to say, how can we take full advantage of the new API environment and fix some of the other problems in healthcare in terms of better care coordination, better quality measuring, and doing all of that. Da Vinci was an effort by the industry to work on that. The challenge of that was the chaos of all the initiatives, the new technologies, the new services, the new cost paradigms, and then an effort to figure out how can we collaborate between the key stakeholders, the payers and insurance companies, private and federal, also working with the providers, and that would be health systems and the independent providers and specialists. And last but not least, the vendors that provide support. So those were the key stakeholders that we knew needed to work together and collaborate. And then how do we make sure we're having real success in this? And that's with implementation guides, pilot projects, and now doing some things in production. In terms of why this was so important, it's because in the real world, we were seeing in how all the standards bodies were working, the challenge of building the standard, evolving the standard, and using the standard is a challenge. Regulations and certification in terms of what the federal government wanted to do, what the state governments wanted to do, what the large billion-dollar payers and providers wanted to do, and how do we certify so people can advance in a common way. And then looking at the barriers to sharing, whether it's people not on the right standard, people on old standards, people with learning to make sure workflows are included. It's not just technology, it's also how do we do the workflow, train people to make sure we've got care. And then as we start shifting to value-based care, the burden of going from an old system to a new system, what can we do with this fantastic new API technology to make that differently? That was part of what went into the success of trying to pull together and collaborate. This picture gives you a sense of who is in Da Vinci. So this has evolved quite a bit. As you look at this picture, I know it's a bit of an eye chart, but you'll see we've got the categories to the left, the provider organizations, the EHRs, the payers, the vendors, and industry partners. There's a little asterisk, and again, each of you will be able to get the slides. The asterisks are who are the original founding members of the Da Vinci project that were involved. This has grown tremendously. In fact, the Rush Medical Center was the first provider that joined, but the CTO was a driving force. When he left and went to another company, that we lost Rush 2 years after. So they're no longer on the picture, but initially they were the only provider. So as a group, we really worked hard to bring in more provider organizations. Kaiser was there in the beginning, but didn't join the first year, but finally did join as one of the largest providers in the United States. But you can see from just looking at the members that don't have an asterisk, you get a sense of how many came after they saw the progress and the success of the first couple of years. At the bottom are the industry partners. And in addition to HL7, having strategic collaborations with HIMSS and NCQA, National Committee for Quality. I've got the A wrong. But working on the quality measures, that gives you a sense of the growth of the coalition that's been working together on the Da Vinci project. In terms of some of the highlights of what we've done, if you look to the left, it's not just about Da Vinci looking on value-based care, it's making sure we're leveraging FHIR as a standard and FHIR implementation guides. So we have, right now, we're in year 2 of patient access APIs. So consumers in the United States are guaranteed a right to be able to get the data. As a payer, I'll indicate my frustration that the number of people that have used it is lower than we'd expect. But again, you got to start somewhere. And in our world, the reality is people's use case and the way we spend money, it's build it. And one of the things that the federal government spends the least amount of money on is marketing. So it's developing this need, having a regulation, making everybody do it. Oh, by the way, maybe we should let the consumers know this is out there. We've got some certifications that have advanced in terms of the EMRs and EMR vendors. US CDI, US Core Data for Interoperability, has moved from 1 to 2 to 3. And as we go from 2 to 3, we've added more than just the basics of the healthcare operations, but social determinants of health is in there as part of the work that's included in US CDI. DEQM, Digital Exchange for Quality Measures, was a great idea, and now it's moving into production. It was a challenge when it was not done in FHIR with APIs. Now it's less of a challenge and more adopted. I'm not going to go through all of them, but sticking with the adoption as an example, number 5 talks about multi-care, which is one of the large large integrated delivery systems, working with the Regents Blue Cross Blue Shield, which is part of the Blue Cross Shield family, to work on prior authorization and align that with work with Epic as part of that effort. So again, showing that coalition in activity, in action. If you go to the right side on industry and policies, the federal government issued requests for information, a request for information where the industry could give feedback to the feds before they did a federal regulation, which is normally done in a notice of proposed rules. And what we were pleased to see was the work of DaVinci was specifically named so that the industry could realize the work of DaVinci was getting close to being put into a regulatory requirement for key stakeholders of the United States to use it. So seeing that in the RFIs was a message to the industry, hey, the feds see that this progress with this coalition is doing well. Slipping down to item 3, the interop 3 rule, interoperability, the third rule that came out did heavily reference the work that was done by the DaVinci project, either as a recommendation or as a requirement. As a part of the team that built it, we sure would have liked there were more requirements. Realistically, many of the implementation guides that were built were then version 1 or 2, so they really weren't quite ready for prime time, but they were ready to have incentives for the industry to be familiar with it and know that they should use it. And then at the bottom of the highlights, we've had members, in addition to the connectathons, going to other places, HIMSS, Vive, WEDI, Work Group for Electronic Data Interchange. So many of the industry groups started having demonstrations, discussions, sessions, so that more people were aware of the DaVinci work, so that they would be aware this is something they should bring to their operation and make sure leadership was aware of that. This is a picture from HIMSS 23 that's in Chicago, which is my home base, just giving you a sense of the number of people that were coming to the HL7 booth. At the HL7 booth, over 30 presentations. They were talking about fire. They were talking about the 24th Century Cures Act. And then the AI buzz was also on the stage as part of work at HIMSS to highlight some of the work of the DaVinci project as one of the fire accelerators. Let me stop because I didn't mention accelerators. DaVinci is one of several. DaVinci worked on value-based care. The Gravity Project worked on social determinants of health. FAST, Fire at Scale Task Force, involved in issues of scale. Where are the endpoints? How am I going to deal with security? How am I going to deal with consent? We specifically did that to separate, because while you're working on a use case, everybody kept saying, well, how does this work at scale? It was real clear. If you try to work on too many things at the same time, you don't get done. So we shifted that at scale work to its own accelerator. So those accelerators do talk. We work with each other. There's coordination at HL7. I think a monthly call between the accelerators, and there's a lot of overlap between members that are, because the association is involved in almost all of them. Key vendors like Epic are involved in most of them, and many of the experts at HL7 cover many of these accelerators in addition to their work group duties. So there's that interplay between the work we do in use cases and building these implementation guides as part of the accelerators, and what HL7 work groups do in terms of moving the standard forward, developing the standard, balloting the standard, and publishing it, and then bringing it to the connectathons. So that's a little bit about the overview. Before I go on, are there any questions about just DaVinci in terms of what we've done, the people we've worked with, before I move on to a deeper dive in terms of some of the work we've been doing? Hearing none, and evidently there's none on the chat. All right. Let's move forward and talk about the actual work we've done in DaVinci. I'm not going to try to go through all of this, but just give you a sense of how to read this chart, because you'll be able to get the slides. With each one of those dials represents an area which usually has one implementation guide. We realized we should group these things. So to the left, we've got the clinical data exchange, which covered payer coverage decision exchange, clinical data exchange, and payer data exchange, were all part of the effort to make sure we're moving clinical data to support on the provider side care coordination, better care for people, and improving it and trying to reduce the price and make sure it works well. And payers, of course, are involved in not only paying for it, but doing quality measures and being very active in exchanging amongst ourselves as people change insurance, usually at the annual basis, as part of how they do that. We realized underneath clinical data exchange, there's foundational things that everybody needs. Member attribution, who is in what kind of insurance with who, who's with what provider, is a thing that covers a variety of use cases. Notifications, alerts to you that, oh, you didn't do your follow-up care, or a doctor, a reminder that you should follow up with that patient. Again, what's the API and the actual operations flow for an implementation guide to focus on that. Health record exchange, remittance, advice discovery in terms of the administrative side of that is also part of that foundational assets. To the right, we realize a variety of things would actually dealt with burden reduction, the challenge to providers and payers, the paperwork, the operational challenges of moving this data, understanding the data, and providing services, whether it's, are you covered with a particular insurance coverage requirements discovery? Do I need to know additional information to approve that service? Documentation, templates, and rules, identifying what kind of information needs to be provided, templates to do it, and what were the rules that might apply to that, prior authorization support, especially in the commercial environment, trying to make sure before expensive surgery is done, what would be the prerequisites to confirm that is the appropriate surgery, the appropriate medication to be done, formulary with medications, plan net directory. Where is the payer? Where is the provider? The names are similar, the services are similar, but you want to get the right payer and the right provider that are associated with that member's insurance. And then cost transparency. Definitely a challenge in the United States where it's covered insurance and there's prerequisite payments, and an opportunity to figure out before you get the surgery that, is this a $1,500 surgery or a $50,000 surgery, and what's my copay, and a requirement that information be made available. Quality, obviously an important part, and we have a variety of things that provide for quality measures. In terms of looking at this, we came up with a metric. If it's green, that means it's mature. Usually it means it's on its third or fourth revision and update of that implementation guide. Active growth means it's beyond basics, but we're actually still playing with it. Least mature means it's still being built. It's maybe in its first iteration, maybe not even gone to a connectathon. So people could just see a simple dashboard to look at the use cases and understand where they were as people were making choices as to what to work on. In terms of our 2023 priorities, looking at that framework, we're looking at trying to mature the guides that we have, align them with federal regulations, and looking at convening people to look at cost transparency, an example, making sure there's an appropriate investment in making sure we can move parts of the DaVinci work forward. And last, on this issue of what we're building in progress, is making sure we've got more members, because we're now beyond the basics. We were originally kind of concerned about trying to make sure the members were familiar with the HL7 process, were committed to the process, had full support of people who attended HL7, people who were involved in leadership at HL7, and had consistency, because this was all new. It was a lot easier to work with people who were familiar with the HL7 process. Now that we've got the process, no, I won't say completely nailed down, but we're open to having people who have less experience with HL7 because we have a well-baked process that they can come into. So we're really opening up the tent, whereas before we were kind of being careful who was in to make sure we could collaborate effectively. Now we've got some pretty clear rules of the road, and we realize we need more people actively involved because we need more people who will not just build the standard, but use the standard. On the right, in terms of our priorities, is looking at industry-wide initiatives and also policy initiatives. Because as we build them, it's not just evangelizing in that small community that are active at HL7, but it's starting to evangelize and get the word out to people that don't go to HL7 aren't active in HIMSS, but actually need to be using the stuff we've built because it's effective. We've used it connectathons. We have some of it in production. We have some in federal regs. So we need a bigger tent of people that are involved in using it. The other thing we've been looking at is to make sure we clarify the guides. They usually built for people who come to HL7 a lot. They're not very good for strangers. So we're trying to do a better job of making the implementation guides of HL7 that can be consumed and understood effectively by vendors and participants and stakeholders that aren't that familiar with the HL7 process and rules. I know this is an eye chart. You're going to have to look at it offline. But what we've done here is on the left side, the community members, it lists all of the members that are actively working at using the standards. So you can see, and across the right, across the very top, are the various initiatives and IGs that we're working on. And we're color coding them so you can see if it's actually a limited use or it's actively moving into production. And let me be more clear here. This is a case where if you're using it at a connectathon, that's good to exercise it and get it back into process through our HL7 process to make sure things we found that didn't work well in a connectathon are certainly not going to work in production. Let's upgrade the guide appropriately so that it reflects improvements that'll make it work better at connectathon. But what we really want to do is make sure these guides are mature and get used in production, which would be the green, where people have made that effort. Because when you go from doing a connectathon to production, at least in the US, now all of a sudden your security people are going to be involved. Your lawyers are going to be involved. Your contracting is going to be involved. We've learned the hard way that in some cases, you need to look at your annual contract between a provider and a payer to make sure the contract includes whatever is the operational implications of using these new standards. It's easy to say, but it's actually pretty hard to do when you're dealing with real data, real at least in the United States, PHI that includes HIPAA implications. And let's add the other new wrinkle, which comes into once we get into health equity and social determinants of health, that was never covered by HIPAA, but it is actually still recognized as sensitive data, whether it's about your race and ethnicity, or whether you're homeless, or whether you're suffering mental abuse or physical abuse. Those things are very sensitive, and how are they being captured and stored is all part of the challenge of moving forward. This is to give you a timeline for 2023. Yeah, that's a lot of stuff we're getting done in 23. Take a look at that as you go from January of 2023 to 2024. We're trying to deal with not only the balloting to the far left, but also the publication process of HL7, and then SDU updates in July. Because again, these implementation guides interrelate with each other. So it's pretty important to make sure you're sensitive to the timing of HL7's process for balloting and publishing, and also the maturity of that STU and when can you use it. So this was an effort to make sure for the industry stakeholders, especially the active participants at DaVinci, that they understood as they're talking to senior leadership, the interaction between these guides and the timing of when they're going to be published, the timing of when they're available, and then that crossbacks with the timing of when a federal regulation may become a reg and when is that required to go into production. All of that, we're trying to make sure people can have a good early warning of seeing when it's coming, those that are following the policy and knowing when in 2025 they may need to be in production. This is an effort to make sure people can see the holistic implications of these guides, along with what's their staffing, what's their challenges, and what's their relationship with the payers and the providers and vendors to do that. So this roadmap was a way to help participants and observers be able to understand where to place their bets, where to allocate staff, and where to plan for their budgeting for the next year to make sure people or budgeting vendors to support are made aware of that. Let me pause and see if you have any questions about the number of IGs, the way we're doing it, before I do a deep dive in just one area to give you a sense of things going on there. Any questions before I go on?
Now, with all the implementation, how do you track like Online.
I mean, it's a lot of exciting stuff this year. Like, how do you, as Da Vinci, track progress in terms of who's actually implemented? And so just that page will be kept up to date, notified beyond just the members, I guess.
Oh yeah, and I'm glad you asked the question that way, Brent. At the bottom of this page is a link. It's on Confluence. So on Confluence, you can expand this, you can look, you can do the deep dive on a particular IG to see who has committed from the IGs. You can go to what's going on at the Connectathons. If you go to the Da Vinci page for the Connectathons, you'll see which IGs are being worked on and who has teamed up before the Connectathon to come, which will give you a sense of which payers are working on which IGs, which providers are working on which IGs. And then even if you as a payer or a vendor provider aren't doing it, most people know who their competition is. Most people know who they work with in the industry. So you can look on that chart and you can say, oh, I know someone at Humana, they're working on this. Let me pick up the phone and call my Humana person and say, can you tell me a little bit more? Or when I go to the work group meeting, knowing what's being worked on at the Connectathon, I can usually, those people that are at a Connectathon are at the work group. And for every IG, it's owned by a work group. So you can go to the work group to talk to people at the work group. Hey, I want to understand a little bit more about this implementation guide. And they'll usually tell you, well, on Tuesday, Q4, we're going to talk about that. So part of this is we're providing the cookie crumbs to know which IG, which members are working on it, and which work group's doing it, and all in, I hate to say it this way, it's all hidden in public on Confluence. It's actually all there, but this gives you a good running start between who's doing what with what guides, and then again, a reminder, you can go look at the Connectathons to see which IGs are testing, and they usually tell you what scripts and what use cases, because most of the IGs can do 2 or 3 things. You're likely not interested in all of them, but when you go to the Connectathon page, you can see who's doing what, who's working on it, and then usually you can find them, especially with Hoover now, at the work group meeting and go chase them down and say over coffee, hey, I see you did this. Could you tell me a little bit more? Because I'm thinking about working on it. Give me some tips. Who can I work with? So we've provided, these are tools to help people understand where to navigate, and between Connectathons and work group meetings in Hoover, how to find someone who can give you that extra level of detail or start you on your journey to get involved in this. Great question. All right, let's do a deeper dive in about 5 minutes, and we'll see if there's questions on attachments. Oh, I didn't mean to go to the end. Wrong. All right, attachments in the US realm or US, because of insurance and the need to usually get approval, especially over higher dollar value or pre-authorizations or approving a claim that seems odd for some reason. I knew the person had eye issues, but I wasn't sure they had kidney issues. And I don't have anything in my paperwork as a payer that you have kidney issues, but I got this kidney bill. So it's like, okay, send me something from your medical record that shows you have kidney issues, because somehow I don't have anything, or I need more information as part of the protocol for something that exceeds a certain cost. Means, oh, it's $20, no problem. 20,000 bucks, I think I need a little bit more information here. So that's kind of the overall use case. So as we looked at APIs, it became clear in the past when you were dealing with needing additional information as part of either getting approval to work with a specialist, even if it's a hospital working with an external specialist and wanting to understand why can't my people do it versus going somewhere else, or a payer saying, I'm not sure I want to pay for that, or it exceeds my normal expectations. That used to be PDFs, it used to be faxes, it used to be, oh, I want to know more about your kidney, and I got the whole 20, 40, 50 pages of a chart, which then meant whether it was the specialist administrative staff or the payer's administrative staff, they're going through all of this over information. The issue here is, well, could we use FHIR and APIs to just ask for what I need? And the EMR vendors having the ability to understand what I need based on the implementation guides that showed some clarity on the process flow to do just that use case. I need this information about this patient, about these specific medical issues, and the ability for the EMR to send me back just what I asked for is a big deal on both sides, because both the providers and the payers were spending a whole bunch of administrative work because there was no easy way to get to just what I wanted. So this was an opportunity that everybody in the Da Vinci world saw, boy, if we could just fix it so that when I can ask for something, the staff can know what to send, or the computer can just figure out what I want based on LOINC codes or SNOMED codes to get just that information and send just what I want. And when I, as a payer or a specialist, receive it, I've got tooling to go only look at what I want. That's kind of the promise of APIs and what we could do with the technology, and make sure we could automate that and get this into real-time processing, or at least get it away from batch and big flows. And then maintenance, documentation, workflows. It's this opportunity where everybody saw an opportunity to take advantage of it, but the issue is how. So clinical data exchange was one of the key things we started working on. As you can see, clinical data exchange, the needles at the highest level, because we've been definitely working hard on that to make sure the process of what are the exchange scenarios that were involved under the snapshot. How can you get involved? Testing it, adopting it, contributing to it. And then we keep track for each one of these IGs. What have we updated? It's on SDU2. We've added a particular submit attach operation. We've commented on the notice of proposed rules. So not only are we, as part of this process of working with an IG, exercising it in connectathons, advancing it, but we're actually adding new features as they evolve in HL7 and they're appropriate. And then whether it's a federal or a state or opportunities to look at proposed rules and use the expertise of all the stakeholders to comment, that's one example of the level of depth that goes into working on a particular IG. The other thing we've done is to try to, it seemed initially like, okay, why are we spending all the time on the diagrams? Well, because most people don't have time to read the guide, don't want to read the guide, and our executives need to know, why are we doing this? What's the business flow in lingo that they can understand? So at the bottom, we've got the healthcare organization to the left. We've got health IT in terms of the provider organization or a payer organization needing some information to make a decision. And then across, identifying the kinds of things I would be exchanging, whether it's a document, missing information that I got. You sent me stuff, but it didn't have what I needed, or I need a specific kind of report. This made it easy for senior business and federal agencies and state agencies to know, why am I doing this? How am I doing this? And not bothering them with the details of an IG and a connectathon. This is what we're trying to do. And if you're interested in the mechanics of it, then they've got an understanding of why they or some of their staff should do that deeper dive. And then we started documenting with that flow on the far right, kind of making sure people understood, yep, we can use XML, but I can also still move a PDF, but it's a lot more easy to move a PDF electronically than to get a fax and try to scan that and move it. So just giving people a sense of who are the players involved and making sure we've clarified from the previous picture, how am I going to use it? Providers talking to each other, attachments related to claims, digital signatures to make sure that our lawyers have said, what did you send and were you authorized to send it? And on this date, the provenance of that data. And then for quality measures, I may need some additional information for my HEDIS reporting, which is something for NCQA and the feds to make sure I can report on quality measures. And oh, why would they do that? Because if you can prove that you've done your quality measures in the United States, you can better reimbursement for that service. Do you get it that month? No, but at the end of the year, it could be a nice multi-million-dollar bump, depending on how large you are. And as you can see at the bottom, we've got 79% of our members looked at that flow and that work and said, yes, I can see the value of this. I understand it. You've given me the information to pitch this to my senior leadership so that they can commit the resources in the budget to follow through on that. That, what you just saw, was a result of the commitment to fund Da Vinci, the commitment to provide in-kind resources to Da Vinci, and for people to have these kinds of artifacts, which again are, someone had to build it. If it was all volunteer, it really would, this would have been a 5-year effort, not a 2-year effort. So this is now running at the pace of the internet. But again, the accelerator process allowed people to commit. And the thing we learned is when someone writes a check, we've learned it doesn't matter whether it's a $10,000 check, a $25,000, or $50,000 check. The effort to go through and get senior management to sign off on spending money usually results in them going, well, why am I doing this? And when they understand why, there's that commitment. Because they wrote the check, they usually have a protocol in most large organizations. What's going on? What's the status? So the commitment not only funded the work, but it created a psychological and a normal process of a closed loop. Oh, I spent the money, what happened? And that kept the energy moving from year to year because they had to pay every year, which reminded them every year, I've got some of my team working on this. How's that going? And the team getting the resources you've just seen to go, oh, well, we can work on these connectathons. Oh, well, there's an opportunity for us to be a leader in implementing it, which puts us as a leader in making sure things that are important to us get implemented in the next generation, or some of the newest technology, the newest directions of healthcare get added to the process. We also did a survey to the members to make sure we understood what across the bottom are the various implementation guides, and now you can see color-coded if it's adopted in red, if it's being adopted in gray, and if people are planning. So now there was a visualization for leadership at HL7 and leadership at the members to understand where's my money and time and my commitment going, and if it's not going, I can work with my colleagues, I can work with the coalition to go, oh my goodness, we don't seem to be doing as much as I thought we should be doing in gaps in care, because gaps in care can help close care coordination. But I can look at that and go, well, you guys said gaps in care was important, but I can look at this chart and go, you said it, we built it, but no one's using it. And then people at least can see and talk about, what do we do? Do we get more members that want to work on gaps in care? Maybe that's one of the ways. Or do we go back to our members and go, hey, I can see this chart. Is gaps in care not as important as we thought? Do we need to downsize our effort here? So the visualization efforts that many of the accelerators do help. This is just an eye chart to give you a sense from at least what's going on in the US government and CMS, the largest payer for these services for both the state programs and federal programs. You can, you measure people by what they spend their time and budget on. So these rules tell you at least what the federal government thinks is important. Now, mind you, the federal government gets guidance from the members of HL7, the National Committee for Health and Vital Statistics. They have a variety of levers to get input. Sometimes they don't get it right, but sometimes we have tools like this to at least provide input when they propose a rule. Notice the proposed rulemaking. Many of the active people who are involved in accelerators, because they're an accelerator, because they're committed, because they've got time and money in, it's an opportunity to directly respond to the federal approach to it and say, I know what you thought we meant to do with that guide, but you didn't quite get it right. Let us give you some input as people who've built it, if people have connected with it, and people are implementing it. Well, let me give you some suggestions on how to make this work better as you make it a regulatory requirement for everybody to use, as an example of, again, things we've done as part of the Da Vinci project to make it clear where regs are doing things and where our guides at Da Vinci affect those. The latest things we've done is the proposed rulemaking on advancing interoperability, advancing the use of FHIR. We put together a group and made sure, separate from HL7's policy group, that the Da Vinci people put in our knowledgeable input to that and giving that feedback. And again, those responses are available again on our friend Confluence, so you can see the kinds of comments that are coming from the business and builders to affect federal regs. So you get a sense of how being involved in DaVinci, being involved in building these guides is now got a response loop back to the federal process. That's what's the update on DaVinci. Questions in the less than 5 minutes we've got left? Got one up here. Hold on for the mic so the people that are on the web can hear.
What's your overall like level of optimism right now?
High optimism, but somewhat disappointed that we've got such discrepancies between, because many of these IGs, again, going back to gaps in care and notifications and member attribution, I thought that was going to move faster, because if I don't know who is in my cohort group, and if I don't know where my gaps are, who didn't come for their appointment and who didn't get their meds to trigger the technology to get feedback to the doctor and say, hey, your patient, you may not have noticed or you somehow missed it, but I can see that they haven't had an exam in 90 days and it's supposed to be every 30 days, pick up the pace. And I thought that would just move better, because that's fundamental to improving care, is getting people to do. And then the other disappointment is, because the patient access API hasn't taken off, the ability for a payer provider to just go ahead and send a note or a link to somebody because they've got an app and I can now influence them directly. That part of it hasn't come to fruition, but that's, I think, the same problem we had with PCs. When they first came out, they didn't sell too long until VisiCalc came out and everybody said, oh, there's a spreadsheet. I want that. You have to have a PC. Well, now that I understand why I need a PC, I'll get one. We haven't made the case for consumers to run out and get access to their own data, because for some reason they're not understanding, if you have access to your data, we're going to be able to talk to you and help you take care of yourself better without yourself forgetting. I know we're not supposed to be the mommy daddy state, but realistically, people are busy, they're doing their job, they're doing their games, but they always pay attention to their phone. So being able to tie these pieces that we intellectually put together at DaVinci and through the FHIR accelerators and HL7, it's disappointing that we haven't been able to close the loop and get consumers more involved in their care. I have great confidence we'll figure out what's that VisiCalc thing that will get consumers to jump on getting an app on their own cell phone. It hasn't happened yet. I think we might need to pay them. Okay, everybody, you're interested. Everybody every month gets $1,000. Somebody's going to win a prize for $1,000. Oh, you can't get $1,000 unless you get your app. It's worked in many areas. You want somebody to do stuff, give them a chance to get some money for it, is Lenel's humble opinion. Thank you for that question. Anything else? Nothing in the chat? Oh, see one. Hold on.
As a follow-up to what you were just describing, what's missing in an app like MyChart, for example, related to DaVinci, prior auth?
MyChart is actually good, because I use MyChart at my provider and everything's in there, but there isn't an easy, not that I'm aware of, there is an easy way to get to, there's no particular app that'll get me to MyChart, and people that use MyChart perceive that as that's from my provider. It's not necessarily my app for my whole care, because your major provider may be on MyChart, but your specialist is on some other system, which I personally experienced, and those things don't talk to each other. So I think that's the value of having an app, that I can get to my main provider, any specialist, and others, but we haven't made the value proposition for that doesn't exist. But MyChart is a good example of the providers providing something that's better. It's similar to a portal, and I'm not sure if MyChart has an app version, never looked for it. But we need to not have that, having everybody have to go to their provider to get their system. That's not as effective as you having something that can get to anybody. And we just haven't made that case. And that's the piece we need to solve. Thank you, everybody. Appreciate your questions.
Thank you very much, Lenel.